Hello again. How is everybody doing? Looks like I got a little bit more to sign on in here. Can you guys see the screen pretty well? Or is it too bright? Sometimes I'm wondering if I mess with the lighting. Can you see it okay on your end? Okay, a little blurry, huh? Now I'm told that when you guys look at the recorded video off of Sue Ellen's iPad, that it's a little bit more clear. Is that correct? It is. Good, good, good. Do you guys have the practical sheets that you can take notes on as you're watching this video? Okay, good. I think, I want to get started here pretty quick here because I don't want to go behind because I normally do talk too much. But one thing I want to reiterate is there has been some questions in regards to when does the practical start as far as the grading of a practical. And technically the grading of a practical starts as soon as you walk in the door because you need to come prepared basically to take this test. So having said that, when you walk in the door, we are already looking, are you dressed in your scrubs? Do you, let's say if you're a female, do you have bobby pins in your hair that's magnetic? Do you have watches on that's magnetic? What are you, thank you, I'll start my recording here. So, when you come in and you are setting your backpack in a chair, you are ready to take a test. The same way as if you would go to the testing center, you walk in and then you actually have to lock up your belongings to go in and take the test. The timing for a practical though is when you close that door to zone 2. So, you are still being graded though prior to that. We allow you to pick your order. We give you a couple minutes to go in and get your table set up. And then we're like, okay, are you ready? And then when you go ahead and start washing your hands and introducing yourself, we are grading you on that. Then you walk into zone 2, close the door and sit down. Then that's when the timing starts. And so, and that's okay. I was told that the time starts when I say the patient's name. We're talking probably a difference of what, 10 seconds? I allow the patients to go in and close the door because there are times that a patient or a student will say, hi, my name's Mary Jo, I'm going to be doing your test. They don't say it maybe out in the waiting room. So, as soon as we close the door is when the time starts, but that's not saying that you didn't do something wrong before the time starts. You still have to come basically ready to work. That's like you're going in for your job, okay? So, just understand that if you come in and you have bobby pins in your hair or you have things in your pocket and you go into zone 4, You're not going to be doing that in clinic. You can't be doing that in clinic. So those are, automatic failures because that's not a safe procedure type of a thing. So I'm hoping this all makes sense to you. I know whether or not somebody starts the clock at 10 seconds here versus 10 seconds there. I mean, I understand, Chelsea, 10 seconds is a lot of time in your guys' minds, but I have, if somebody is doing their practical and it gets to be 25 minutes and 10 seconds, I'm not going to be that tight to say, oh, sorry, you didn't pass it. We're talking if you've gone several times over, or a lot over the time frame, and we can get a pretty good feel of, does this student really feel confident in what they're doing, or do they really need more practice before we can really check them off of saying, yeah, they've passed this. To me, it's not the timing thing that's the issue. It's more of the how comfortable and how confident are they in setting up their pictures and in scanning and and putting the patient on the table. I mean, if it takes them 20 minutes to try to figure out how to get them into the magnet, that's telling me they're not real sure how they should be doing this. So I'm just wanting to reiterate that when you're doing these practicals, as soon as you come in to take, you're technically saying, I'm ready, I'm here to take the test. You shouldn't be having metal in your pockets. You shouldn't be, having your cell phone on you, because again, that's potential to, when you're working in the field, to forget that I can't go in there. I can't go in there and help a patient. I got all these things in my pockets. You need to be cautious and be thinking of all that prior to you coming into taking this practical. So hopefully, kind of makes sense. Just kind of want to reiterate all that to you. But, it's the whole safety feature. The very top of the practical is where we check mark that, yeah, the patient was dressed, or the student was dressed properly. They are free of metal. They are, those three things we check, and we're watching that, for you guys. So that's just a little bit of my speech here. We'll get started on how to scan, and we're going to start with the knee first. And this happens to be a right knee. There is a case in here that's also a left knee. So when you are practicing this on your own, I would be practicing both right knee and left knee, because you're not real sure what your patient's going to be, which knee are you scanning. And you really need to understand how you're angling for the left knee is going to be different than how you're going to angle for the right knee. Only because the knee and how they're externally rotated are going to be on opposite directions, right? So I'm going to go ahead and we're going to load the knee protocol in here. I'm just going to close out and cut these out here because I wanted to show you that we do have a right knee protocol in here. There is also a left knee protocol. So you can pick, if you're doing a left knee, pick this one. If you're doing a right knee, pick the other one. So the very first survey here, what we're going to do is make sure that we have the right coil. And we're going to basically pick the Sense knee coil right here. And all of these elements are going to be loaded on. And we're going to click proceed and start. Now our first survey here says it's a full field of view. In some places, what they do is they do a big 45 centimeter field of view where they can see both knees, okay? Other times they might just go directly to a survey where it's automatically offset to the right for you, okay? So, you know, that's kind of like just different ways it could be saved for you. If this is a full field of view, notice I got a little bit of the left knee showing here. Then I can go back and I can go ahead and say, okay, I want to make sure that I got everything over into this right side. And click on my field of view here. So now I'm just going to do a 3-plane pilot right over my right knee. Click that and start. And on this particular case, series 3 is already into my axial images. So we're going to set up our axials off of this 3-plane pilot. And I'm going to load my 3 planes in here. I got my sagittal. I'm going to zoom up my axial here. And these are my 3 pictures to choose from. And I have my coronal. Okay. Okay. So, like again, just to reiterate, some places will do a full field of view transverse where you can see both knees. Off of these both knees, then you can set up your 3-plane only of the right knee. So here is really my 3-plane pilot. I'm going to set up now for a proton density axial spare, which is really a fat set. Okay, so I do have my volume box, which is this green box. I'm going to turn that off for now. And I need to go ahead and set up a field of view that would be appropriate here. Okay, so if I want to straighten my lines up here, whoops. So notice right off the bat, I can tell I need a bigger field of view because if I look over here, I'm cutting off part of the patella, right? So I'm going to go ahead and say maybe about a 140 field of view. And because the knee in the axial plane is almost like a circle, I'm going to really use probably a square field of view. And if I look on my sagittal here, notice anterior to posterior, I'm including about everything, and I've only got a little bit of this skin fold here. If you feel like 140 is too tight for you, and if you go 150, I'm okay with that. Probably 140 is going to be the smallest field of view that you'd want to pick. So now with the 150, I'm not going to get any wrap A to P that I have to worry about in here, okay? My slice thickness is 3.5 at default. I have 3.5. I can change this to default, which would be a 0.3.5, right? Okay. I need to make sure I cover above my patella and then get all the way through I'm gonna move these up. This is my tibial tuberosity here. You can see where the patellar tendon is inserting to this little bit of a kind of a contour anterior to that tibia bone there. So I have 24 slices. I'm going to add about 4 more slices here. I'm going to be above my patella, so I'm into my quadriceps tendon. And I'm making sure that I'm actually right into where the tibial tuberosity is located. If you think that's a little too tight, add 2 more slices here. And now I'm all the way through where the patellar tendon inserts, okay? I don't really need to angle anything. You know, that knee is positioned in here pretty straight. So, you know, I don't need to angle this way or that way. I can do a straight axial. I'm looking over at my coronal, and that looks good here. I've got good coverage right to left here, plenty of field of view right to left. Okay, so I'm next going to go to my contrast, and I'm going to make sure that I have PD weighting. So I have a TR of 3,355 and a TE of 80. So somebody tell me, is this what you want for PD? Okay, Chelsea, what would you want? What do you want to change? Or Christopher? Type in there what you would change these to. TE to 35, okay, I like that. It's going to give me good signal of my articular cartilage, yep. So now I have a 3,355. I got a TE of 34. We're in that range, 3,000 to 6,000, and it's, you know, and it's in 2 packages. Normally for PD, that TSE factor is around, you know, 14-ish, okay? Remember, above 20 is what the turbo factors for T2. So pretty much I have PD weighting. I have 3,000. Yep, that sounds good, Chelsea, 12 to 15. I have a high TR, I have a low TE, that's going to give me PD. Now I'm going to go ahead and go down to my fat suppression, because this is a spare. And I want my inversion delay to be 1/3 of my spare TR. So my spare TR is 200. Very good, yes. So 1/3 of 200 would give me about what? If I would say 68, 60 to 70, okay, so let's do a 68. That's going to be about 1/3. I should get full fat suppression. 66, yep, that's fine, but we're in that range, right? So this will give me a nice PD spare fat set, right? So now I'm going to go ahead and think about, okay, my fold over, my phase direction is right to left. And if you want to keep right to left, I'm okay with that, but you always have to think about, oh yeah, there's that other knee over there that you might want to turn on fold over, okay? Or if you tell yourself, well, you know what, I'm going to do my fold over A to P. I do not need fold over, but maybe then you'll want to go ahead and turn on a couple rest slabs. Change it to free here. And then you're going to go ahead and go above your slices and below your slices. So I'm going to give you that option. You tell me, how do you want your face to go? Do you want right to left? Once you are out here scanning in the field and you scan a couple knees and you say, you know what, my coil doesn't even pick up the signal from my other knee. Even if it's right to left, I never get wrap. Perfect, great. Then you can use right to left. But you will learn that as you're scanning here of, well, what can my coil do and what can it not do, okay? So you tell me which way you like it. If you want A to P, if you want right to left, but what I want to understand from you is I might ask you a couple questions that says, okay, so tell me right to left, you know, do you want to turn on fold over or not? And you can say no, because I've scanned this several times, I know what my coil does, or I can say, yeah, there's a chance I'm going to get fold over, so I think I'm going to want to turn it on. It's just that you're thinking of what you are programming for your protocol here, okay? So the next thing is I want to make sure my shim box is in the area that I want it to be. So I'm going to position my shim box to cover my anatomy. And if your shim box doesn't ever stay like that, go to your shim align here, click it back to no, and then it'll allow you to keep where you are positioning your shim box. Now notice I don't need to shim all the way out right to left because there's no anatomy right to left. Keep it where you're going to be within skin to skin here. Okay? Hopefully that makes sense to you. So we can turn on this, I can turn on my volume, and notice that my volume box, if I turn that back on, is just within my anatomy of my knee, right? It's 3 minutes. Do you like your time? Yeah, I like my time. So we're going to click proceed and start. Now notice it says go to viewing and point out your patellar cartilage and your lateral condyle. We can do that now if you want, or we can go at the very end and pull up all of these pictures for anatomy. But when you go to viewing, you go to the eyeball. I'm going to load in my case. I'm going to go to my axials here. And what I'm going to ask you to do is tell me, where is the patellar cartilage at? So technically, what we're looking at here, I can blow it up here. Now this actual knee picture has some motion on it, but it's right behind the knee here. This is what the radiologists are looking at. Now, notice that they repeated this knee. Do you notice a change in this image or this series? Look how nice and crisp this is. So your cartilage is going to lie. If I change my window and level here, it's that grayish appearance behind the patella. Looking for the lateral femoral condyle, well, if I'm looking at all of these pictures here, maybe I'll go a slice here. Notice that I'm starting to look in my tunnel here, okay? And I see this structure here kind of hugging on that inner part of the tunnel. That's my ACL. And that makes sense because this is more of a rounded condyle, where this has more of a flattened appearance to it. So my lateral femoral condyle is here. The medial femoral condyle is here. And sometimes you have to page through these to kind of really get to, okay, well, what's lateral, what's medial here? If you go all the way through, notice down lower, here is my fibula, and here's my tibia. L is flat, M is round. There you go. Very good. I like that. So you can even page through all of your axials here to figure out which is lateral and which is medial. I'm going to flip back to scan 3 because look how nice of pictures these look versus, I'm trying to blow it up here, these pictures here. Do these look as crisp to you? Don't you see like there's lines going through this? You don't really have a good picture of your patellar cartilage back here. Can you tell the difference of what motion looks like? Maybe not so much on these images that I'm showing on the computer, but I think once you come into class and you're looking at these on the monitor, you'll be able to see that there is a difference of motion, okay? Try to straighten this up for you. Okay. So we're running this one, right? We got the axials that's running. Number 2 is to set up a PD sagittal fat sat. Whoops. There we go. So right away, I'm going to go ahead and pick that better axial. I'm going to turn off my volume box. Okay, I'm going to go ahead and just kind of straighten my lines up here because I want to find the image that's going to allow me to angle where I want to angle. So I really am looking for this nice little flattened appearance. And there's about 2 or 3 slices that you could use, okay? So if I bring that back in here, notice my field of view box right off the bat. That is huge, isn't it? I do not need a field of view that big. I'm gonna go back to like, let's go to like a 16 or a 160. Maybe even a 150. This is where it's going to truly depend on the size of your patient, of how big you need to go with your field of view. So with a 150 field of view, I have a good picture of the quadriceps tendon. I have the patellar tendon as it attaches to the tibial tuberosity there. I've got good coverage anterior and posterior, so this looks pretty good for a field of view. My slice thickness is going to be 3.5 at default again. Change it to default. Now I can position my slices, and if you want, you can turn off your red lines so you get a nice little ruler. And many times I'll take this center thing and I'll say, okay, I'm going to draw a line straight through where that lateral femoral condyle is. Once I get my angle, I can bring it back into the center. Notice how I have a slice, this center slice, slice 13 here, is going right through that ACL, right? If you want to turn your lines back on, you can. Then you basically want to cover skin to skin because I want to make sure that I get all of those collateral ligaments that we're going to see. Not only in the sagittal, we're going to see collateral ligaments best in the coronal, but I want to still get skin to skin in this knee sagittal protocol, okay? If I look over at my coronal of my sagittals, I pretty much look like I'm cutting straight through, right? It's a good sagittal in the coronal plane. I really am only angling it in my axial, off of my axial reference here. So once I have my number of slices, I have 24 slices here. Okay, that looks good. I can now go to my weighting again, and I have 3,000 at 30, and my turbo factor is 20. Is there anything that you would like to change? Right, turbo factor to 14. Okay, and I notice there's a couple questions here that angle the axial on the what. What you're angling off of this axial image, you're setting up sagittals, we're angling with the lateral femoral condyle. And the ACL, Courtney, is right, this dark area, which is right on the inside of this tunnel, okay? This is lateral, and I know that this dark structure in this tunnel is my ACL, because the ACL will always lie to the lateral aspect of the knee. Okay, so I like my slices, I like my field of view, my TRTE, we have 3,000 at 30. You can change that 30 to like a 35 to 40, right? Okay. My spare TR again, I have 250. It's on 80. 80 times 3 is 240. That's pretty close. We can keep it at 80. Perfect. phase direction. I got to look at my sagittal here with my field of view. I can do my phase direction as head to foot or A to P, but remember, you've got your popliteal artery that travels to the back of the knee here. I'm going to want my phase direction to be head to foot. So I'm going to go back. I'm going to change this to head to foot, and I will need fold over because I'm going to have the femur wrapping in and my lower leg here wrapping in if I don't. Okay? Do you want to turn on rest labs? You don't have to for here. Some people will still turn on a rest lab and put superior and inferior rest labs. That's okay. There is nothing wrong with that at all. So you're welcome to do that. Now my shin box, I got to turn that back on, and I now got to go ahead and make sure that I'm just shimming through anatomy here. Yes, Shalika.
So if you decide not to put the rest labs, but wouldn't you have the arteries and the veins?
Yep.
The blood from that, so wouldn't it be best to have a rest lab or no?
Well, you could, but my artery and veins are traveling head to foot, so that's going to go right through the back of the knee, and I'm really concentrating on this part of the knee. So I'm okay if I see blood flow going to the posterior aspect of the knee. I'm not going to have any, I'm not going to worry about motion in this area. It's going to keep that all to the posterior aspect. Now, but that's, having said that, because we do have a proton density with this high TR, I probably have enough TR to put in 2 rest labs, and that'll be okay. So if you want to turn on 2 rest labs and put 1 inferior and or superior and inferior, that's totally fine. Does that make sense? Yes, no? Okay, good. So now I'm just opening up my volume box there to kind of cover what I will need to cover. That looks good. My time is 2 minutes and 42 seconds. Do you like it? Yeah, that's a good time, isn't it? It's under 3 minutes. That's good. So you can then go ahead and click start. We can go to viewing. We're going to pull up series 6. Okay. This is my proton density fat set. It's got the fat signal in my bone suppressed. It doesn't matter, Christopher, because, don't necessarily think about, well, it has to be under 3 minutes or it has to be under 5, because it all depends on what you're scanning. All depends on how many slices you have. And it kind of all depends on how many, sets of pictures are you scanning. So there's really not a definitive number to say, oh yeah, it has to be under 3 minutes, or no, it has to be under 5. You just have to kind of understand that, for somebody to hold still for 3 minutes, it should be pretty easy. It's not hard, you know what I mean? Whereas for somebody to hold still for 6 to 7 minutes, yeah, then you're kind of getting up there. That might be hard for them not to move for that length of time. So hopefully it makes sense to you. Okay, going back to the pictures here. So I want you to show me an abnormality in the posterior horn of the lateral meniscus. Okay, well, first of all, I got to find out what's lateral. So I can page through here, and if I go all the way to this outside, notice that this is my fibula. So I know that starting with slice 23 or even slice 26 here, as we go down here, this is my fibula. So now as I start going up, I am getting into the lateral meniscus here. Okay, so that would be my lateral meniscus. That makes sense to you? This is my fibula. This is part of the meniscus here. It's starting to break up. We got our little bow tie appearance here. And if I magnify this up, you have a nice blackened anterior horn, and then you have this bright signal going through the posterior horn. If I even blow up this other one here, can you see that there's an abnormality in this posterior horn of the lateral meniscus? Good, good, good. Okay, so we can go back to scanning. Again, we can always go to viewing and go to scanning. So now we're going to go ahead and set up a T1 sagittal, and I'm going to set up my T1 to be exactly like my PD sagittal. I have 24 slices, right? So I'm going to set this up, 3.5 at default. I had a 150 by 150. And I have 24 slices. You just got to make sure you angle it with this lateral femoral condyle again. We had it straight on my coronal here, because technically I'm going straight through my femur here. I can straighten up my box here, my field of view box. I got skin to skin coverage, okay? I got to make sure I'm T1 weighted. I'm 900 at 17. Do you guys like that? Yes, do you like a 900 TR for a T1? Yes, I want it to be lower there. So I'm going to change my range here to be, let's say, maybe 300 to 700 here. All right, so that's going to give me a TR of 438, TE of 17. That's good. That's a good T1 weighted. I have a TSE factor of 3. That will give me a T1 weighted image. Okay, so I got my contrast the way I want it. Now, make sure voxel size will get a matrix of. So basically, I'm going to tell you that I need my matrix here to be higher or lower. And you need to know then, what do I do to my voxel size? So if I say I want my matrix size to be larger, that means I need my matrices, or my voxel size, to be smaller. Oops. 0.4 by 0.4. Oh, it's giving me a conflict. It's telling me that I'll have to go change my TSE factor here. But we're going to go back. And let's see, maybe I'll just change this to, this was a 0.52, 0.52. If I let that, and if I change this to 0.4, I've made my matrix higher. Does that make sense to you? If I need my matrix to go lower, then basically what I'm saying is I need your voxels to go bigger. If I go to 0.8 by 0.8, notice now I'm at a 188 by 187. So understand the relationship between voxel size and your matrix. Okay, so that's basically what this is all about, is that you understand. I'm going to say, well, tell me, I want your matrix to be higher, or I really want your matrix to be lower. How would you adjust your voxel size? Okay. Phase direction. I'm going to still want my phase direction here to go head to foot, and I'm going to go ahead and need fold over turned on, and it is on. What's my time? 2 minutes and 46 seconds. What's my SAR level? I'm below 2.0, so I am in normal SAR mode. Looks good. Start. Go to viewing. I'm going to pull now series 7, which is my T1 here. Okay, this is my T1 weighted image. And I'm going to say, show me the ACL and PCL. Okay, well that's going to be in the center, right? So if I look for the ligament that attaches to the back here, I know that has to be my PCL. Okay? What's tricky about this one here is your tibial plateau here. And notice that there's really nothing attached to it. This is an ACL tear. And if I go back to my PD to the center, I can pull up my PCL, but there is fluid all within the ACL. And notice, see how this little band is? Think about it as a rubber band. This ACL snapped and it's not connected no more. So this is a full ACL tear, okay? So that's basically just what you need to show me. If you look at the musculature back here, this is all swelling and edema in the muscle behind the femur bone. So actually some of these hamstring muscles have been torn as well. Okay? Now, if I pull up an image of the left knee, if you pick a left knee MRI, then you're probably going to be able to pick out the ACL and PCL a little bit better. Okay, so we're going to go to the last set. Set me up a coronal T2 spare. Coronal T2. All right. So I'm going to turn off my volume box to get that out of the way. This is a coronal. So I actually need to open my field of view better here, right? So let's say 120. Okay. I'm going to straighten this up here for now. I can even pull up a better sagittal. Okay, I can pull up a better sagittal here. There we go. Okay. Field of view wise goes, that looks pretty good. Do you see how I made it a little bit skinnier right to left? I did a 140 foot to head. And because I'm looking at maybe more of a rectangle here of anatomy, I can bring in my field of view in the left to right direction. I can bring that into 120. Okay, it's going to save me in time. Slice thickness 3.5 at default again. Okay, this time what I'm going to do is I'm going to turn my slices off. Now I want to angle and use my little line as a ruler. I want to take a slice that's going to be level or parallel to the posterior condyles of the femur here. So I want to make sure I'm at this level, which would be the lateral, and at this level, which would be the medial. I can almost use this as a ruler. And that's the angle that I want to choose for coronals. Your coverage then needs to be, for sure, you need to get all of the bone here, right? But because there is some soft tissue damage back here of the hamstring muscles, I'm going to go ahead and add some slices and pretty much cover the entire area. Okay? You said that's called posterior condyle. Correct. These are the condyles at the posterior femur bone here. This is your lateral condyle. This is your medial condyle. Okay? So I have 30 slices. I'm going all the way through the skin here. So I'm basically almost covering skin to skin. I'm going to cover all of this muscles in the back because I can see here that there's a torn hamstring muscle. Many times you're going to see Baker's cysts back here. So you're going to make sure you're going to want to cover that Baker's cyst as well. Okay, so let me go to my contrast now. I have 4,000 TR. I have a 60 TE. I have a turbo factor of 11. Well, I know that I need to go, this is a T2 spare, so I'm going to go up to probably 80 or even 100. Okay, I can go ahead, my turbo factor's in the 20s. I have now 4,753 TR, a 100 TE, 22 turbo factor. I'm going to go to my spare TR, which is 100, and it's 316 over here. So if I even do 105, I'm about 1/3. Now notice that that adjusted the spare TR a little bit, but I'm still about that 1/3, right? Phase direction. I'm doing a coronal, so I'm going to look at my coronal box here. I can go head to foot or right to left. Again, if you go right to left, you might have to worry about the other knee wrapping in, okay? Or you can go head to foot. I am going to need fold over though, so okay. You want to go, Chelsea, you want to go head to foot with rest labs. Sounds great. So I'm going to go back to head to foot, okay? Notice how it did change my field of view, so I'm going to go ahead and now I have to do right to left at 120 and foot to head at 140, right? So when you change, make sure you look at how it changed your field of view box, okay? T2, 80 to 120, yeah, I like that, Christopher. And if you want to add your rest labs, here's where you can add your rest labs then. And then you can put a rest lab superior and inferior here. Okay, that looks good. Let me turn on my volume box because let's not forget that I got to bring that. And again, if it doesn't keep it, go back and go to your shim align. Oops, in the geometry page, your shim align here. Where is that at here? When I'm trying to look for it fast here.
Hey, Mary Jo.
Yes.
I was worrying about the T2 thing, and I didn't hear what you said about the rest labs. You said we do want to turn those on, or
You can. Again, how you scan and how somebody else scans could be different. So if you want to turn them on, that you are perfectly fine to turn them on, because what that will help with is minimize flow from that popliteal artery, you know, in your image. Now think about it though, in the coronal plane, because I'm gonna pull up a coronal here. Okay, oh shoot, do they even have a coronal? They might not have a coronal on here. Here's a coronal. There we go. Shalika, what's your question?
my question is that for one of them, you said we didn't need it because we were scanning the knee and it was behind it. But this one, would it be the same or is it different? Why we need it this time?
I'm not saying that you need it, but that's what I was just getting her to talk about is here's your coronal images, okay? So the very posterior aspect on this particular case is right here. This is your very last slice here because they actually scanned it starting with number 1 from the patella on back. So your flow motion is going to be in these last couple slices. Once you get into the center of your knee here, well now your flow's behind it. So I shouldn't have to worry about flow as I'm getting into this anterior part of the knee or the middle part of the knee, right? So again, but is it wrong to want to turn these on? It's not saying it's wrong. You have enough TR. You have enough TR to get 2 rest labs in, right? Because you're, you know, again, it's another RF pulse. So if you put them on, that's okay. Some people might scan it like that. Others might say, you know what, I don't think I need it, so I'm not going to turn it on. And that's where, it's hard teaching you guys something that's not so black and white. Because again, it's if you're going to turn it on, my question would be to you, okay, well, tell me why. And you could say, well, I just want to minimize flow coming from, the arteries coming down and the veins going up. Okay, I get it. Others might say, you know what, I'm not going to turn it on because I'm not really worried about flow once I get into my knee joint. Okay, it's just that you understand what you're talking about. Yes, Shalika.
So if we see that tear in the muscle back there,
Yep.
so it'd be kind of smart to turn it on because it's in the back of the knee.
Very good. That would be, and I would say, yeah, I like that. Yeah, I like that thought process. So again, that's going to be your call of what you want to do. Okay, going back to here, I'm just positioning my volume box. Just making sure I'm just kind of getting in from the skin here. I'm covering it all the way, head to foot here. So you can kind of see, I'm going to turn on my box here. I just went in a little bit right to left because I don't need to shim air, do I? Okay, and that looks good. My time is 4 minutes. That's a pretty good time. You can hit proceed and start. Okay, go to viewing. Pull up series 5. I want you to point out the bone contusion or the fracture in these slices. So if I kind of go through my coronals here, do you notice that on this area of the femur, how it's all bright here? And you can see that there's like a fracture line within this distal femur as well. And if you're trying to figure out what's lateral and what's medial, well, here is the fibular head. So I know this is my lateral side. So I know that up here, this is my lateral condyle of the femur, right? So that's just what you need to point out. And then also point out the MCL. Well, over here then is your medial side. And look, I can see a ligament that attaches from the femur bone all the way down to my tibia bone. This is your medial collateral ligament. Does that make sense, hopefully? This would be a meniscus. These triangles are a meniscus, so this would we would call this the medial meniscus. We would call this the lateral meniscus on our coronal images here. Okay? Any questions on the knee? Good. Okay, so quickly then, I'm going to go ahead and we will go through the tib fib. So I'm going to just pull over I better pick the tib fib case here. So it's going to be tib fib, attention right. There is a lower leg here. Let's see if that's the only tib fib we have. Okay, we're going to pick the Owens lower leg here. Okay. So I'm going to go ahead and pull over my tib fib protocol, my lower leg here. Okay. Notice I'm going to go ahead and make sure my coil for a tib fib, I'm going to use the Torso XL coil. I'm going to turn on all the elements. Okay. Notice I have both tib fibs showing up, and right here I don't have a good sagittal, do I? Because I'm doing a slice right through air here. So I only have these axials to go by and a couple coronals to go by, okay? So in the real world, we would do another survey, and then this time I would get a nice sagittal, either of the right or of the left, but we're going to do it of the right here. And I can bring this over here. Just do another localizer here. Your reference scan, you can go ahead and just pick it like this. You can position it right over to fill all of your field of view here again. In case we want to use sense, because we have a torso sense coil. And then I'm going to have you set up for a T1 coronal, okay? And it's telling me to include the knee joint down to the ankle joint. No, we didn't do a reference scan on the knee coil because at that time we're not using any kind of parallel imaging. If you have a sense knee coil and you want to turn on parallel imaging, you will then need to do a reference scan. Good question though, very good question. Okay, so I'm going to go and just see what kind of localizers I have. Okay, so notice on this Owen's leg, my second survey, I have a better localizer for a coronal and now a sagittal. There's my sagittal. So I have now an axial localizer, a coronal localizer, and then sagittal localizer. And actually, I'm really kind of cutting off the ankle joint here. So what we're going to need to do is kind of just draw, in our mind where the ankle's at. On this particular case, they just must be looking more at the proximal lower leg, so they didn't worry about the ankle joint here because they could see the knee joint there, okay? So what I want you to do is to select a field of view from the ankle or from the knee joint all the way down to the ankle. And what we're going to do is we will do these. I will tell you whether or not this is going to be unilateral or bilateral, but we'll just set it up for bilateral for now, okay? So I'm going to need my field of view now then to go, let's go 380. I'm going to assume with 380 that we're going to get into the ankle here. And I have my knee joint. I can still see all of that knee joint there, right? Now, I can bring my field of view right to left in a little bit. And that'll save me in time. Maybe even go, let's say 300. There. So let's say that because both of these tib fibs are more of a rectangle shape, I'm going to go ahead and get the ankle or the knee joint, and I'm going to assume I'll catch the ankle joint here. In the real world, you could do another localizer to make sure you can see the ankle joint, okay, but we don't have that in this particular case. So I'm going to go ahead and do 4 millimeters, 4 thickness at default, okay? And I'm going to just make sure I cover both of my tib fibs. And a lot of times what I would like to do is I'll draw a line and say, here's my tibia. Your fibular bone in the axial is just a little circle because as it goes down into your leg, your fibula gets smaller. But I'm like, do I need to angle it? I'm right in the center of my tibia bone here. and right into the center of my shaft of my tibia bone there. So I really don't need to angle these coronals. If I look over at my sagittal, I can take my little ruler and say, you know what, I'm going to angle it slightly. So I have a slice going right through the long bone of that tibia. Okay? I can turn my slices back on and say, well, did I catch all of the muscles here? I have 24 slices, and I can kind of maybe page through a couple of my sagittals. I only got a couple sagittals. That's probably the least amount of slices that you would want. If you feel like I'm going to take a couple more just to make sure I don't miss any part of the back part of those muscles in the lower leg, then go ahead. It's 26 slices is what I have. So I like the angle here because I'm going to get a nice slice through both of those lower legs, in the tibia to be exact. I like my field of view. I'm going to go to my contrast. This needs to be T1 weighted. Well, it's 500 at 80. Well, I know 80 is too high. I'm going to bring my TE back down to like a 20. Let's say, can I go to, probably can even go to a 15. I'm getting a conflict because it's telling me I have too much trains, and I'm going to bring my echo trains down to 3. Okay? Let's say here. There. It is, with the echo train of 3, it wanted me to up my TE to 20 here. So I have 570, I have a 20 TE, I have a 3 turbo factor. That's going to give me T1 weighted. My phase direction, well, I might as well pick right to left. There's nothing on either side of both legs. So I'm going to pick a right to left. I do not need fold over. I probably don't even need rest labs. Okay? Do you like the time? It's 6 minutes. And if you don't like the time, what was the TR? Oh, the TE I have is 20. So if you don't like the time, you did a reference scan, you can turn on sense. You have a sense coil, and bring your P reduction factor up to like a 1.4. Now you've dropped it down to 4.5 minutes. Looks good. You could look at your motion. Well, it's already 2 necks. I really don't want to go to 1 neck, so that's not an option. I'm telling you to change one parameter that will increase your spatial resolution. Well, there's a couple things you could do. If I try to cut down my field of view, I'll get better resolution, but I'm getting pretty close to the max there. So another way to do resolution would be in my voxel size. So I can change, it's at a 0.4 by 0.6. I could bring the 0.6 down to 0.4, and that's going to go ahead and give me smaller voxel size. It upped my time again. So now I might want to go to my P reduction factor and say, okay, now I want to go to 1.7, or maybe you'll want to go up to 2 and make it down to about 4.5 minutes again. Okay? So again, those are just things that you can play with. Proceed and start. You're going to set up your stir coronal to be exactly the same, and I'm not going to set it up for you here because you want the same field of view, you want the same amount of slices, you want to angle it with your shaft as you did for your T1. The only other thing now is to adjust your parameters and make sure that you get the TI to be in that 140 to 150 range, because with the stir, remember, we're suppressing fat in the fatty marrow of our bone so we can see if there's any abnormalities in the bone that shows up. Verify your time. Do you like the time? And then change one parameter that will increase your signal to noise. Okay? Set up a T2 spare axial. So here's a T2 spare axial over your gastroc muscle. Okay, I'm going to go ahead and pull up now a better, first of all, I can pull up a better coronal, which is here, okay? Now look at these better coronals. They actually got all of the ankle, even into the foot on these. And we're going to do these unilateral, okay? So we're going to go over the right side. I'm going to need to increase my field of view to probably about at least a 120 here. Maybe even a 130, okay? And I know that my gastroc muscle, okay, is going to be at the very posterior aspect. So we're talking in your gastroc muscle is back in here, okay? You can kind of almost see, it's kind of hard to tell, I guess, you know, but it's like, you know, the big thicker muscles in the calf here. We're going to do 4 millimeter at default, and I'm going to add probably a bunch of more slices here. We don't have a good sagittal. You know, in the real world, we'd have a nice sagittal where we could pull up, because then that would allow me to kind of even page through these sagittals and see exactly where that gastroc joins into the Achilles. You can almost maybe say that this black line here is part of the Achilles here. But what you'll want to do for these axials is just make sure you start out in a joint. So we're going to make sure we get a little bit higher in that knee joint. Get all of that. We'll probably even go to a lot more slices here. Let's go to about 55 slices. So if I would go ahead and get all the way down through at least over over half, trying to see if I can pull up where here's the Achilles on the left side. I can't really see it on the right because this is my last slice, but you can see this Achilles, and then as it's going up, so, you know, we know that right now is part of that gastroc muscle here, because that gastroc attaches to the Achilles. So, you know, 55 slices, even if you wanted to go up to 60 slices to be sure. Go back up to where you can see your joint, kind of position it down. You should get all of your gastroc muscle by including this in your T2 spare here, okay? So if I go to my contrast page, the shortest TR, the TE's at 80. I'm going to change my turbo factor like to that 22 range. My actual TR is 7,432 with a TE of 80, turbo factor of 22. That looks good. That's the shortest TR you can get with 60 slices, okay? My spare TR is 70, and I have a 247, so if I change this to at least 80, that's going to give me 240 some. So we're in that 1/3 range. It's an axial. If I go right to left, I'm going to have wrap. So I don't want right to left. I want to make sure I'm A to P. Then I do not need fold over. Okay. My time's about 5 minutes. Do you like it? You can say, yeah, I like it. Or, you know what, I need to make that a little bit faster. I'm already at 2. I don't want to go to 1. Again, I have a sense coil. Use it. So I can go ahead and do a 1.4 here. It brings it down to 3 minutes and 21 seconds. So that looks good. So I'm telling you here that you notice in your images that a mass or tumor that's demonstrated within the right calf where the gastroc muscle is. It's not a tear. And then you need to now set up a T1 spur fat sat. Basically, you're just going to set this up identical to what you set your T2 spare as. and make sure it's T1 weighted, and that would be it. Do we need a shim? We do not. Oh yes, yeah, we do need a shim. I'm thinking of a stir. Back on here, we need to turn our shim box on because it's a spare. Go under my contrast. The shim's on auto, so if I go to volume, then I can see that it's going to be on here, and then I want to make sure that I cover the entire area. Thank you for pointing that out, Shalika. Good job. And then proceed and start. So then your T1 axial spur, I don't have it in my protocol, do I? So I'm going to have to go back to my protocol here and find a T1 spur. Or I can go to this T1 and say, okay, I'm going to just copy. Whoops, I think I cut it, didn't I? There we go. We'll bring it back over here. So I can just go to any T1. I can set this up identical then with the number of slices that we had, which was, again, did we have 55, 60? These are coronals, but we're really doing axial, so now I'm going to change this to the transverse. We had 4 at default. Okay. I'm going to make sure I get my joint in. My field of view, I think, was what? Was it 130? I can pull it back up to double check here. But once you have everything set up, I'm going to make sure I'm T1 weighted. So I'm going to go to a 3, get my TE back into that 30 range. Okay. My maximum here, if I even up it to 700, will that change anything? My actual TR is 629. Now I need to go to my fat suppression, and I say I want to turn on spur because this is what's going to make it a fat sat. Okay, I can go ahead to my shim and turn on my volume box. I can move that back up to where just what I did for my T1. It's telling me it's 12 minutes long and I'm at 2 next. Well, that's when we're going to have to go to my sense, turn on sense, and probably go up to 2 to bring it down to 6 minutes. But it's a long scan, but look it, I got 60 slices. If you say I want to bring my time down a little bit, then open up your voxels to, let's say, a 0.7 by 0.7, and now it's down to 5.5 minutes. So again, it's just playing and understanding parameters. As we go, you know, we kind of keep manipulating parameters back and forth just so you understand that how you can adjust parameters to bring time down or use your sense to bring times down, especially when you have the ability to have sense coils, okay? And yes, I'm using a 130 by 130 here. So that's how you set up for a tib fib. So it's not hard at all. If anything, you're just going to be playing with parameters, but as you are practicing, the more you practice, I think the more comfortable and the more at ease you're going to be of, yeah, okay, this isn't too bad, I can do this. Any questions on anything? How do you guys feel? Not too bad, hopefully? Okay, good. Alrighty, well, I'm going to go ahead and turn off the recording here. And again, whenever you are practicing on your own or, you know, with a lab instructor and you have any questions that you feel that you're not getting answers to, please text me, email me, You know, I want to clarify things to you as quickly and as thorough as I can. Okay? All right. You guys have a good 2 weeks off otherwise. Take care. 2 weeks from me anyway. Bye-bye.